Good afternoon, everyone, or good evening. I guess it's going to be about that time of the day where we're talking about evening, but thank you all for logging in for this lecture. I hope you are interested as much as I am as interested in providing this for you. As Brittany mentioned, my name is Aric Steinmann, and I'm one of the pain fellows here at the Stanford Pain Management Clinic. And, I wanted to start by asking you this rhetorical question. It's not too rhetorical, but has anyone here had a hard time trying to rate their pain when they're asked to do so by a medical professional? And I feel that if you've answered yes to that question, that you're really not alone, okay? And I developed this presentation with the goal in mind of improving the communication, or really like enhancing the dialogue, if you may, between patients and the medical professionals, especially those of us in the pain management realm. I hope to first do this by giving you ways that we look at the different dimensions of pain and how that contributes to its effects on your life. And then second, I want to educate you on like the different dimensions of pain and how that also affects your life. Okay, so at the end of the lecture, my hope is that you're better prepared to answer the question, how do you rate your pain today? All right, I have no disclosures to discuss on this topic. And unfortunately, we don't have the means to go around the virtual room here and make introductions. But before I dive deeper into the topic, I just want to introduce myself to you to make it feel a little more personal, a little bit more who I am and where I'm coming from. So I am originally from Wisconsin. I went to the medical school at the Uniformed Services University in Bethesda, Maryland. I did an internship in internal medicine in San Antonio, Texas. Then for 5 years, I served as a Air Force flight surgeon stationed in both New Mexico and England. I then came back and completed a residency in anesthesiology again in San Antonio. And I then practiced anesthesia for 4.5 years in the Destin, Florida area. And now I'm currently a pain fellow. I graduate in just under 90 days, not that I'm counting or anything. And then I'll be going on to Anchorage, Alaska after fellowship, rejoining the Air Force. So let's imagine this not too hypothetical scenario, if you will. All right. Let's say you've arrived at the pain management clinic, in life or virtually, and then someone asks you that all too familiar question, how do you rate your pain today? Happens every time, right? You see, think about that. And I really wonder, how do you answer that question? I mean, it should be obvious to all of us, like, how do I rate my pain? Obvious, shouldn't it, right? Well, the good news, if it's not so obvious to you, that I feel like you're in good company. And I know this because I've met hundreds and hundreds of patients in our clinic, both this year and patients from the 15 years or so that I've been practicing medicine, thousands of patients, I guess. And if you're having difficulty answering that question, you're not alone. As it turns out, rating your pain isn't as easy as a task as one would think it should be. Why is that? Well, in preparation for this lecture or this presentation, I did a PubMed search, which for those of you who don't know, it's kind of like Google for medical literature. So it's the real Dr. Google. And I searched the phrase patient's rating of pain. And surprisingly to even me, this search brought back a result of 26,561 articles. 4,028 of those were published in the last 12 months alone. So my interpretation of this finding, of this PubMed search, is that if rating your pain or a patient's ability to rate their pain was so easy to do, then there'd really only be a handful of articles on this topic, and probably they were all published 100 years ago. But That's not the reality. So why is it so hard to rate our pain? Well, many of you who have attended some of these lectures may have heard of this before, but for the newcomers here, the International Association for the Study of Pain, or the ISAP, has defined the meaning of pain for us. And they define it as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. All right. They further went on to say that pain is always a personal experience that is influenced to varying degrees of biological, psychological, and social factors. All right. And through their life experiences, individuals learn the concepts of pain, and a person's report of a painful experience should always be respected. And I hope all of you receive a good deal of respect when they talk about their pain, especially in our clinic. And so here we see the biopsychosocial pattern or model of pain. And that's how we look at pain at the Stanford Pain Management Clinic. Because this is how we look at how pain affects someone's overall health. So biological, I want you to think of the physiologic pathology that a person might experience. The psychological portion of the model, think of the thoughts, the emotions, behaviors, and the psychological distresses such as fear and avoidance that influence someone's pain. And then social, we'll look at how the socioeconomic, social environmental, cultural factors, work issues, family circumstances, all like their economics, how those all relay into what we consider as the balance between, health and illness. And this is obviously one component of it in the overall health and wellness, but from the pain model, we like to use this. So why is this important? It's important to accurately assess pain as a key factor in determining someone's to assess their pain so we can figure out the best way to find effective treatments for them. So let's get back to the question, how do we rate our pain today? And I guess what most of us are probably most familiar with is by asking about the intensity of your pain. So in adult pain medicine, we typically look at 3 different pain intensity rating scales. We have that you've probably all kind of been a little bit familiarized with. We have the verbal rating scale, also known as the VRS. It's probably the most basic, and you're all the most familiar with. And it's simply reporting a number, and it's typically between 0 and 10, where 10 or 0 is no pain, and 10 is the absolute worst pain imaginable. Next, we have what we call the numeric rating scale, and it's very similar, but it looks at like a set of numbers where you as the patient actually circle that number, and you don't use the prompting of a physician or another medical professional to circle that number or to tell you or to report that number back. So you circle it for us. And again, 0 is no pain, 10 is the worst pain. Then lastly, we have the visual analog scale, and that is a meter-shaped scale in which you as the patient marks off on a line that demarcates where you feel your pain is, and it has the extreme of where we consider the left end as no pain and the right end of that scale as the worst pain imaginable. Fortunately, all 3 of these are fairly easy to administer. There's not a whole lot of difficulty in administering it, but there's some difficulty when it comes to language barriers and extremes of age. All right. So in here, like this next slide, we got the numeric rating scale. Obviously, this is where you maybe fill out a form or a survey online that we have. You click a button or circle like, hey, my pain is an 8 out of 10 right now. And here in the visual analog scale, you might see something like this, and you're like, what is this? Where do I go? There's no pain, and the pain is worse as possible. And you think about it for a second, and you're like, yeah, my pain is right about here. All right. So both of those are fairly easy to use against, all the cultures and languages, been adapted to many. The visual analog scale is actually typically a 10-centimeter measurement. So we actually, like someone from our clinic would actually measure that. They'll lay a ruler down and actually measure in millimeters to get as precise as possible to see what that scale might be. And, really this is utilized a lot in epidemiological and clinical research papers. And frequently I've read articles where they talk about the change in the VAS measurement. And, before I go on, I really want to talk about and not underestimate the importance of the concept of change over time with all these rating systems that we're going to discuss. Because we are not static beings, okay? We do change over time, and it's important to assess these changes over time when we talk about our pain. And, I don't want it to be any surprise that as we do experience these changes that, we notice them and we're able to express that change, that difference. Additionally, we have what we call the Wong-Banker FACES scale. This is developed more for the pediatric population. It initially is for patients the ages 3 and over. However, it was later frequently applied in the geriatric arena as well. And you may have seen this where you have the faces and the kid may circle like, oh, it hurts a little bit, or, they're hurting a lot and they circle that. And it's just, again, it's a measure of intensity. And it only takes a little bit of coaching for both our pediatrics and our geriatric patients to be able to really convey how intense their pain is. All right. But, in the end, what I want to drive home is that the intensity rating scales that we kind of discussed, they just measure one of the components of the pain experience. All right. A 10 for one person could easily be a 3 for another person. And now, there are many reasons for these differences in the perception of pain. But we'll talk about those later on during this presentation. But in an effort to highlight the efforts of my pain psychology colleagues, we can use various different coping skills that we can employ, which we'll talk about later, that may help us decrease that intensity. All right. In the end, I want to say these scales are really incapable of deciphering the complexity of like that, unique pain experience that we all experience when we have pain. And it don't really explain how any improvements due to these symptoms. All right. So in the upcoming slides, what I'm going to do is go through several of the indexes that we use in pain management, indexes, scales, inventories, etc. They're typically used in pain research and clinically. And I want to make sure that you guys are exposed to these. And I feel that they can help all of us better prepare the dialogue for the next time that you see a pain management professional, and to help you translate a little better how you experience your pain. All right. Unfortunately, due to the practicality constraints of the hour that Dr. Jones had mentioned that this presentation is limited to, I can't cover all of the scales that are used, both clinically and in research and pain management. But, I will try to highlight several of the more frequently utilized scales, and kind of explain like the different dimensions of pain how they look at different dimensions of pain, so that in the end, you guys are going to be just a little more prepared to help convey that information to us in our clinic. So without further ado, one of the next things like that we talk about in pain is, let's kind of describe, where do we actually feel the pain? So many of you who are patients in our clinic, they may have seen this image here before, based upon the gender, male or female. And this is what we call the Collaborative Health Outcomes Information Registry Choir Body Map. All right. And this map was recently developed by the Stanford University Division of Pain Management as a means to better standardize and digitize locations that you may be feeling pain. So what they did was basically took several experts and sectioned off all the different areas of the body and looked at those different areas as they kind of contribute to several of the known pain syndromes. And they tried to get those all collected. So if someone was to select the front part of their shoulder, we would lead us down a certain diagnostics algorithm than if they circled the backside of their shoulder, because there's different reasons why someone would have pain in those different areas. All right. And they basically took about 100,000 different surveys from patients as well, and created this map, and has been recently validated in a paper that was published by our clinic earlier this year. So after we kind of ask about their intensity and the location, a lot of times we want to talk about, how do you describe your pain? So what I really want you to focus on is those adjectives that we use to describe pain. And that was first addressed by what was called the McGill Pain Questionnaire, or the MPQ. And it was, a tool that we use to assess pain quality. All right. So it was developed back in the 1970s, and it's still used today for pain research and in the pain clinical realm. At the time, it was really considered revolutionary or evolutionary, depending upon how you look at it, because it asked the patients about how it was the first scale that really quantified this subjective experience of pain. All right. It was the first one that kind of asked questions about the sensory qualities of the painful experience, as well as also evaluated the affective qualities of the painful experience, with the goal of better subjectively describing the overall pain experience. And it has since been validated for many painful conditions. It's been used now. There's different versions that are used for specifically neuropathic pain and non-neuropathic pain states. Interestingly, it's been translated in over 20 different languages. And, I present this scale here to, really make you aware of the adjectives that are, commonly used to describe that painful experience. A lot of times we talk about, oh, it's a burning pain, it's an aching pain, but in your heart of hearts that it's actually something even more than that. And looking at, if you at some time before you come to see your next pain management provider, you look at this scale and you just kind of run through how other words that you might consider. Look at these words such as punishing and cruel, tiring and exhausting, heavy and sickening and fearful. And if these symptoms describe your pain to some extent, I really want you as the patient to make that aware to your provider, like how much this is affecting your life, this sickening, this cruel, or this punishing pain. All right. And then we look at, how does pain affect your function? So the next tool that I want to talk to you about is what we call the brief pain inventory. And it was the first tool that was developed to look at how pain interferes in the lives of the pain sufferer. All right. And it has a couple different variations based upon the length of the tool. Most people use what's considered like the short questionnaire, just due to a little more completeness, and still allow some brevity, because unlike the numeric rating scale where it's just 0 to 10, it takes a little bit more time, and it's important for everyone to have that time and really think through those questions and get through the questions too. All right. Because what's one of the problems with like sending out questionnaires is that it can be very onerous to the patient. We want to make sure that when you're doing these questionnaires, that you're able to focus on these questions to really give us the answers back as honestly as possible. This questionnaire was first developed to assess cancer pain, and it also has been validated in non-malignant pain states as well. So here on this screen, we see the brief pain questionnaire. And I want you to appreciate a few things. First, you see that the scales, the numeric rating scales comes back here. And it takes it in different contexts as like, how bad is your pain in the last 24 hours? What was the best? What was the average? All right. And on the second column here on the right, we look at how our pain treatments are providing relief at a percentage between 0% and 100%. Hopefully, as you go down your treatment protocols, as we treat you more in our clinic, you move more towards that 100%. All right. We do call it pain management because we don't expect 100% relief all the time, but we want to make that pain as manageable as possible. So that's a little bit of a trickiness of like the limitation of this, this scale. All right. And then if you look here, the BPI also tries to look at how mood, mobility, work, and sleep are affected by the pain. So I was talking to Dr. Jones about this presentation on Friday, and she recommended kind of going through some scenarios of these different indexes. And here's one like that I thought might be a way you could incorporate this index the next time that you see a pain management provider. So you can say, well, Dr. Steinmann, my pain now is really just like a 2 or 3 out of 10, but at night, oh, my pain goes up to an 8. And because of that, my sleep is significantly interrupted by my pain. And I just can't fall or stay asleep. And consequently, I'm very grumpy, and I'm afraid to become quite an unpleasant person to be around at home and work. And if you look at that example that I just talked to you about, using that information that I gave to you, we talked about mood, we talked about being able to do work, we talked about relationships and sleep and kind of enjoyment with life. So that's what my goal is with you attending this lecture, looking at these different scales to try to provide that to your pain management professional the next time that you see them, and not nearly the next time, but all the times you come and meet us. All right, the next scale that I want to talk to you about is one that kind of looks at what does your pain keep you from doing? And the scale that came up with that is the Oswestry Disability Index, also known as the ODI. It was developed in 1980 and then disseminated at a meeting in Paris of the International Society for the Study of the Lumbar Spine. All right. Yeah. As such, this scale really looks at like the subjective level of function and disability that someone has as it pertains to their pain. However, one thing is this scale too, as I wanted to point out, has been validated for the axial back pain, or what we call like the pain that we have in our spine. We call that the axial spine. or axial skeleton, and for other non-lower back pain conditions. So it's not just a back pain scale. It can actually be applied to pain in different areas of your life. Currently, it's one of the most used measurements to track the change following treatments. And again, I want to bring up that idea of change and following treatments or different interventions as we go through our life with the pain clinic. It's been used in literature pretty extensively. Hard to find many topics in pain medicine that don't look at the ODI as a measurement. And really, it's the improvement in the ODI that we really like to look at in pain management. And here is a scan of the ODI. And again, we look at here, we have our old friend pain intensity because everyone's so used to it. It starts out the index, the questionnaire, which I guess probably helps people get in the right state of mind. And it starts out by asking some of the more basic activities of daily living, but then it kind of goes on to some of your more advanced or more important activities like your sleeping, your sex life, social life, and ability to get around, you're traveling, right? So I think the ODI is best illustrated, an application of the ODI is really well illustrated by an interaction that I had with two patients recently, all right? I had one patient who was telling me, her pain doesn't bother her much of the day. She's a retiree, so she spends a lot of the day just reading, but her pain is most bothersome to her when she wants to try to leave the house. So her pain is causing her a significant amount of social phobia and like leaving phobia of leaving the house as well. So even though her moment to moment, the pain isn't that bad, but the pain really becomes more problemsome to her at these higher level of functions that we talked about with social life and traveling. And then contrast that to a different patient that I saw recently who had if you think about the disability this patient had, he was having pain in his wrists and was mentioning that he had a very difficult time with hygiene, especially bowel movements. He was having a difficult time wiping himself after a bowel movement. So you can imagine that type of patient is going to have a different understanding of the ODI than someone who at baseline doesn't have much pain just on their day-to-day, but when they want to go out and achieve some of these higher level things, that's when their pain comes into play. So I really want you to think about, I guess, from that example, just how much is the pain disabling you, or keeping you from enjoying what you want to do? And then my next scale that I want to introduce to everyone really highlights the idea of how does the pain affect your coping ability? And this is measured by a scale that we call the pain catastrophizing scale. But I think a better term for it would be the pain coping scale. And what it does is it helps to quantify the individual's pain experience on a more psychological level. And it does it by asking questions about how you feel and what you think about when you are in pain. And interestingly enough, this scale is probably the scale that's most well completed, even if you're not experiencing pain at the moment, which is kind of an interesting concept if you think about it. So again, this scale, it evaluates the role of psychological factors, how they influence the trajectory of recovery after an injury or the onset of a painful disease process. And this scale was developed with an observation that people in need of improved pain coping skills frequently have symptoms of what we call rumination about their pain, which is kind of like the idea of, when I say something like, I can't stop thinking about my pain and how much it hurts. That's rumination. Magnification is the concept of when someone thinks, I'm afraid that, my pain is something that is so bad that if I don't address it or don't pay attention to it all the time, something serious might happen. And that may all be true, but it may also be just a magnified understanding of your pain. And then also patients with some coping skill needs, they might notice like some helplessness, that they need help in managing of their pain. And a thought or an expression that I might hear someone say is something more along the lines of, there's nothing that I can do to reduce the intensity of my pain or how much this pain is keeping me from enjoying my life. So those are, rumination, magnification, and helplessness. Those are kind of three like areas of like, coping that we can look at. And here, this is the actual components of the pain of the PCS, the pain coping scale. And if you read through these various components of this scale, you'll get a sense of how these questions here are really getting behind the intensity of the pain and how it like really bothers you of the pain. And it's not necessarily even the pathological process itself. It's really how it's affecting you from a psychological standpoint. And so again, if I may, I'd like to plug my pain psychology colleagues, because they're the professionals that may best help address your score when it comes to your evaluation of this scale right here. When I hear my patients use some of those phrases that I mentioned earlier, like my pain is so intense, I can't not think about it, or I have to think about my pain because I'm fearful that, if I don't, something very bad could happen. These are the folks that I typically talk to them about how I feel they would benefit from a referral to my pain psychology colleagues, because this leg of our treatment algorithm, they're best at managing that aspect of the pain. And you may, those of you who are in our clinic or are patients in our clinic, you may have heard something that we talk about a four-legged chair of how we look at like the treatment of pain, kind of going back to that biopsychosocial model that we talked about at the beginning of this presentation, where we had the overlapping circles of biological, psychological, and social circles. We look at the treatment of pain as like a four-legged stool, where some of the treatments could be medications as one leg, psychological interventions as another leg, physical therapy interventions as a third leg, and interventions as a fourth leg. And using as much of those four legs as possible to really help evaluate or help develop a very stable stool of treatment for you, if you follow that analogy for me. All right. And then next scale I want to talk to you about is how does your pain affect your sleep? And this is a scale that really isn't truly a pain scale, but we use it a lot in pain literature and clinically in pain practice, because sleep quality is an important aspect of pain. All right, first of all, there's a lot of different studies about the incidence of bad sleep out there, or sleep disturbances, if you would. And on average, I've seen somewhere between 15 to 35% of the adult US population has some degree of a sleep quality disturbance, mainly in the ability of falling asleep or maintaining sleep. And second, why it's relevant to this conversation here is that poor sleep quality can be an important symptom of a pain disorder. All right. So these two, even though sleep isn't necessarily a pain condition, it really helps us in the pain field follow patients and address like one of the symptoms of uncontrolled pain. And they're also relevant in psychiatry. And our pain psychologists also have some different, I guess, programs available to folks who have sleep disturbances. It's not uncommon for people who have pain to have significant anxiety and stress. And obviously, anxiety and stress can really contribute to a difficulty in sleeping. And that's why we use this Pittsburgh Sleep Quality Index, or the PSQI, frequently in the pain management arena. And here, this right here is basically the PSQI, and you'll see terms here where it looks at the quality, the onset, and like the amount of sleep disturbances. But it also is very interested in how much that we need medications to help us with our sleep, or what's the effect on our daytime activities when it comes to our sleep. And if we use the pain or sleep as a surrogate for measuring our pain, that makes sense when we talk about medications and really the effect on our daytime activities. Because if we looked at all those other scales that we talked about, we included assessment of the activities that we've been trying to do or trying to improve and track. All right. So I think one of the ways, like if you ever fill out this PSQI, and you notice that you have like a high score, you might want to bring that up to your pain management provider or to your primary care provider, just to talk about to really engage in the quality of sleep and what we might be able to provide to help you with sleep the next time that you meet with us. All right. And then the last scale that I want to bring up tonight is what we call the Patient Reported Outcomes Measurement Information System, or also called PROMIS. And it is a NIH-funded initiative for clinical research and practice. It's been developed and validated for these patient-reported outcomes, or PROs, for both clinical and practice research. And it's basically set on a person-centered measurements that evaluates and monitors physical, mental, social health in adults and children. And I think one of the greatest benefits of this PROMIS system is that it really monitors the changes over time. It does probably the best out of all the different systems that we have in pain management at assessing this change over time. And hopefully this change is always for the good. But hey, let's be honest. the change. We can have days where, or weeks or months where our pain is worse, and we expect the change to get temporarily worse, right? So, again, this is a scale that's been applied for the general population, obviously adults and children, and those with all different chronic medical conditions that are possibly painful. It's a survey that's not short by any means of the any thoughts, but there's 41 questions on pain interference and 39 questions on pain behaviors. And that's the baseline promise program. For those of you who are patients in our clinic, you probably have come across the survey that gets emailed out to you to be filled out prior to your appointments. And what you're filling out is a lot of this promise survey. And we recently incorporated the neuro quality of life survey questions as well. So if you have done that, you understand the extent and breadth of this survey. And I won't have all those questions for you on another slide, unfortunately. But in lieu of that, I ask you all to fill out that form that is emailed to you the next time that you're seen in our clinic or for follow-up, or if you've never filled it out before, I really encourage you to fill that out to really help communicate that your pain issues to your pain providers. So I guess the last little plug I want to put in with the promise and the choir surveys that we send out is I really want you to think about those questions when you're answering them, because that's going to really affect how we potentially look at how we treat your pain. So the next time that you're filling it out, really, I hope that you spend a moment or two on each of those questions and reflect upon how that pain has been affecting that area of that's being questioned. All right. And so in summary, we looked at the complex experience that is pain. And I invite you to look at how pain affects you in terms of intensity, the anatomic location in your body, the quality of pain, using different adjectives or descriptive words for it, the effects of the pain on your physical and your social functioning, sorry about that. I guess also I want you to look at how the pain affects the degree of disability it may cause you, how you may feel the need for improvement and coping skills of the pain, how pain affects your beliefs, your sleep, and the daily interference of your pain. So, in the end, I hope that you can look at these scales, and the next time that you are seen in the pain management clinic, I hope that you have an opportunity to review some of these scales so that the next time that you're in our clinic, you're able to possibly use some of the information that we talked about here to better prepare yourself for engaging us in really figuring out, really teasing out how that pain is affecting you personally. All right. Because if we don't know that very personal way that it's affecting you, we're not going to be able to best treat you. We're obviously going to be able to give you some good treatments, but to really tailor that therapy to you, really improving that dialogue. And I hope by what we presented today will help improve that dialogue the next time that you're seen in our clinic. And if you do those scales or those different indexes, and you notice that you have like some high scores, I want you to think of those high scores as an opportunity to improve yourself, right? See what and look for the improvements with the therapies over time. All right. And I really want everyone to fill out the choir surveys when they're emailed to you. You know, and I guess like the last thing I really want to focus on is that even though we might notice like a high score or a severe effect on our life that pain may be causing, I want you to look at it as like, this isn't an insurmountable thing. All right. We want everyone to feel empowered that we can all achieve more by working together in this pain clinic, that we're going to get you moving in the best possible trajectory towards a pain improvement to manage that pain. And in the end here, we have some of these resources that we talked about that Dr. Jones had mentioned that are available to everyone. And here are some of the references that I used for this presentation.